Polypharmacy, oh my God.
So, for the purposes of this slide and the beginning of the slide, what we want to define polypharmacy as is 5 or more CNS medications being prescribed at one time. And there was a study done in 2011 with OEF, which is Operation Enduring Freedom. So that was our activity in Afghanistan. And then Operation Iraqi Freedom, which is OIF, okay? So this study was done in 2011, and the reason it's important that you know that that's who they were looking at is these veterans were relatively young people. So we're talking about maybe 20 to 30-year-olds who went to war either in Iraq or Afghanistan, and now are being treated for mental health conditions. And we're seeing that 8.4% of them are being placed on 5 or more CNS acting drugs, and that those diagnosed with PTSD, depression, or TBI had the highest rate of being prescribed multiple CNS agents, and that polypharmacy independently predicted suicide-related behaviors by overdose in this population. The next research that I'm going to comment on is with an older age veteran population. So now they looked at veterans over 50, and here they defined polypharmacy as only 3 or more high-risk medications. And in our older veteran population, we found that these individuals were 7 to 11 times more likely to commit suicide than controls.
You know, you look at that, you say, well, I don't know that polypharmacy is causing the suicides, is it? Or is it that the nature of the illness underlying the drive to get 3, 4, 5, 10 medicines means that the disorder isn't under control? And that's just so it's not like stopping the medicines is going to save their lives, it's treating the underlying illness more effectively? What do you think?
I agree with you. And I also agree that this isn't, I don't think anyone who maybe is not seeing veterans considers this a problem unique to the veteran population. I think all of us in the practice, even me in child psychiatry, patients will come to me on 3, 4, 5 agents. But I think what's unique to the veteran population is lack of continuity of care, which I think contributes to the polypharmacy. And so, for those of you not familiar with the military, I was in the military for about 28 years, if you count my schooling and other things. During that 28-year period, I moved every 3 to 4 years. My patients, when I became a psychiatrist, moved every 3 to 4 years. And it's not like we moved together, right? So I'm getting new patients all the time, they're getting new providers all the time, plus they may be deploying for 6 to 12 months into a location where they have to engage with a new provider. And I think we're probably all a little bit to blame for when we present with a new patient, or a new patient presents to us, and they tell you what their symptoms are, we just add another medication to deal with those symptoms. We don't always look at what they're already taking and try to maybe maximize one agent or withdraw agents that we feel are no longer effective. And so the only thing I found in the military that was constant was change. And unfortunately, that happened while they're on active duty. But then the biggest transition happens when you leave active duty and you go to the VA. And again, I don't know how many of you are aware, but the DoD and the VA were not on the same electronic medical record. So you've got this huge transition where you have had years of care under an electronic medical record called ALTA, and then you leave and go to the VA where they use VISTA. And it wasn't really until probably the last couple years of my service that they at least started being able to access some of those records and look a little bit at what was going on.